My name is Kayce Ataiyero, and I'm Communications Director for Congresswoman Robin Kelly and the Congressional Black Caucus Health Braintrust. I'm happy to be here with you today. Our plenary now is guidelines for treating heart failure and hypertension in African Americans. As you may have noticed, we're running a little bit behind schedule. So what I ask is that after our panelists give their presentations, if you have any questions, if you could follow up with them afterwards so we can start our luncheon on time, I would appreciate that. With us this morning, we have Dr. Jackson T. Wright, Director, Clinical Hypertension Program at Kayce Medical Center and Case Western Reserve University. Dr. Keith Ferdinand, Professor of Clinical Medicine at the Heart and Vascular Institute at Tulane University School of Medicine, and Dr. Ola Akinboboye, Associate Professor of Clinical Medicine at the Weill Medical College at Cornell University. So without further ado, I'll turn it over to Dr. Ferdinand.
Thank you very much, Kayce. We discussed last night that we knew that there was a possibility of our time being truncated, so I'll try to make my remarks focused and brief, but there are some important points that I want to make. We're talking about heart disease, hypertension, heart failure, and I'm going to specifically focus generally on disparities as it relates to cardiovascular disease and hypertension. Dr. Wright is going to discuss some of the new guidelines which actually loosen our goals for therapy, loosen them, make it easier to not take medicines. And Dr. Akinboboye is going to talk about heart failure, where you have profound disparities. Here are my disclosures. So we know, and most of you are aware, that health, life expectancy, and care has improved for all Americans over the last century. But the distribution of these benefits has not been equitable. There are still mortality gaps. We call it the white-black mortality gap. And a large proportion of this is not due to drive-by shooting or HIV, but to cardiovascular disease. Cardiologists, we have an acronym, CVD. Specifically for African Americans, where I'm going to make most of my comments, there's a higher risk for hypertension, diabetes, which is a comorbid condition, obesity, heart attack, which is myocardial infarction, stroke, CKD, chronic kidney disease, cardiovascular mortality, and premature cardiovascular death. This is from Tom Frieden, who is the director of the CDC. This is his comment and not mine. Black men and women are more likely to die of heart disease and strokes than whites. The second bullet point, coronary heart disease, CHD, and stroke, not only the leading causes of death for all Americans, regardless of race, ethnicity, but it accounts for the largest proportion of the inequality in life expectancy between whites and blacks. And the unfortunate thing is that these disparities persist despite the existence of low-cost, highly effective preventive treatment. So we're not talking social science. This is not theory. These are dead bodies at the side of the road. This is life expectancy in the United States over the last several decades. You see at the top, white females having the highest life expectancy, at the bottom, black males. Driven again, not by the unfortunate violence that we see in our community, but by cardiovascular disparities. Note black females in the green and white males in the orange. About the same. So being a black female, you lose the benefit of being female. The life expectancy and the disparities are profound for black females. Now we use the term race and ethnicity, but as we know, these are very crude terms from a truly scientific point of view. And race, to a large extent, is a proxy for a lot. There may be some individual biological or genotypic changes across continents of ancestry that predict responses to various medications and may actually increase certain types of cardiovascular disease. But at the bottom of this Venn diagram, you see the environment, diet, high sodium diet, high saturated fat, lifestyle, living in a low SES environment. I grew up in the Ninth Ward in New Orleans. You can't get a good night's sleep sometime with gunshots ringing out and police bum rushing the house next door. And exposure to toxins, lead and other pollutants higher in disadvantaged communities. So these overlap to lead to disease. This is from the National Health and Nutrition Examination Survey. The good news, in the middle, you see the gray for awareness. African Americans actually have a higher rate of awareness, and that's because of some of the programs of the Association of Black Cardiologists and the International Society on Hypertension in Blacks, and the late great Dr. Saunders from Maryland, doing outreach in beauty shops and barber shops and churches, and at the Bayou Classic and the other classics that you have around the country. It's come to fruition. We're seeing awareness. Treatment is high now in the African American community. Unfortunately, there still are some gaps in terms of control. The black bar, the worst awareness, treatment, and control, the lowest, is not African Americans, but Mexican Americans. Now, it's a little bit different from what you would expect. Mexican Americans don't have more hypertension or more severe hypertension, but in terms of being aware and treated and controlled, it's less. And a lot of that is due to access to health care. So what's unique about African Americans as it relates to hypertension? Obesity is part of the problem. Over 50% of women have a BMI over 40. Higher salt sensitivity, low plasma renin, which may be driven by certain polymorphisms. There may be more of a tendency for the kidney to hold on to sodium. That being said, Americans in general eat too much salt. People who live in the Southeast have more hypertension than people who live in other areas of the country, regardless of race, ethnicity. And those geographic differences in the prevalence of hypertension may be related to differences in lifestyle. There may be more vascular function dysfunction, where the blood vessels clamp, where you have less endothelial function. The inside of the vessel doesn't dilate as well, so you have a tight vessel, and the vessel itself can hypertrophy. Attenuated nocturnal fall in blood pressure, big words meaning your blood pressure doesn't go down at night. Again, some people think there are genetic factors there, but it also may be related to lifestyle and exposures. Where you live may have an effect on your blood pressure. Greater comorbid conditions, diabetes. We have a lot of diabetologists in the audience, both from the public health and the clinical sector, and they have identified African Americans having higher rates of diabetes. Physical inactivity and family history. Family history is difficult to predict, and many of our risk calculators, we don't even use it. I know it sounds funny that doctors don't even talk about it. And that's because it's difficult sometimes for the patients to tell us exactly what is their family history in terms of premature risk and hypertension. They just don't know. But if you do know, family history can be a profound predictor of the rates of not only hypertension, but also coronary disease and heart failure. This is from my friend Tarawa Good. She's here at Georgetown, and this is her Venn diagram. She reminds us that the patient is the problem. That's what we're focusing on. It's not about us going around the clock. At 1 o'clock, you have the family, which probably should be a little bigger part of this diagram. The healthcare provider at 4 o'clock, which probably should be a smaller part of the diagram. The community, huge part, and the healthcare system, which probably overlaps everything. The Million Hearts is the overarching goal of HHS to try to decrease by 1 million heart attacks and strokes using various means. NHLBI, National Heart, Lung, and Blood Institute, Your Tax Dollars at Work, has wonderful materials. It's in what's called the public domain. That means that you can take it, you can print it in color, you can hand it out, you can put your name on it, you can do what you want, you paid for it. And these materials are often underutilized. My approach to healthcare is that every patient and every patient's family should get these types of materials, and you can see across the top the various race, ethnicities that they have materials related to address disparities. And there are specific brochures for African Americans on preventing and controlling blood pressure. Patients like to hear stories and see people who look like them in terms of how to control some of these conditions. So what can we do from a cardiovascular point of view? I'm a cardiologist, but if you're not, what can we do to address these racial disparities? Number one, raise public and provider awareness. That's what we're doing now. Those of you who are clinicians, you should be able to articulate these data. Those of you who are not should be able to promulgate these data to those who don't understand that these disparities are real. They are related to life expectancy. They are related to disability with stroke and heart failure, readmission to the hospital. This is not social science. This is not about just giving an edge to minorities. Expanding health insurance coverage. I'm from Louisiana. I live in New Orleans. 29.9% of people don't have insurance. We just opened up a community hospital in the ravaged New Orleans community. And the patients come to the emergency room with poor health, undiagnosed conditions, and no insurance. Third bullet, improving capacity and number of providers in underserved communities. I'm proud to say that I practiced for 3 decades in my native 9th Ward. Didn't have to be there. Had all the degrees behind my name, all the little letters that make you accepted anywhere in the country. But I felt that the best doctors need to be where the people need it the most. Increasing knowledge for the causes and interventions to reduce health disparities. You're going to hear more about that from my colleagues, Dr. Wright and Akinboboye. So in conclusion, uncontrolled hypertension is a major burden in the African American community. There are adverse effects on the heart, cardiac, on the kidney, renal, and on the brain, cerebral events. This is not social science. We're talking about real outcomes. Therapeutic lifestyle changes are needed in our community: low salt, DASH diet, physical activity, moderate alcohol, healthy weight. This is the bedrock of care. Patients do need medications, but without lifestyle, we're not going to get there. The laissez-faire approach, meaning don't do anything at all, leads to adverse outcomes, and if we're going to improve it, we have to link high quality care to minimize disparities in treatment. Thank you very much.
Ms. Ataiyero, Dr. Pickering, congressional staff, and Congress persons here. I'm certainly pleasure to address this audience regarding a potential huge threat to our communities. And this is the result, actually, of a process that was, in fact, supposed to be beneficial. My disclosures are listed here. Wish I had more. The purpose of my address is to discuss the new U.S. guidelines. Now, this is a complicated slide, but I want you to focus on the column on the left side of the slide, where it starts off with goal systolic blood pressure. And the column on the extreme left-hand side says goal systolic blood pressure of less than 150 millimeters of mercury. All the other columns list 140/90 as the recommended target for blood pressure treatment. That is patients less than age 60, those who have diabetes or chronic kidney disease. The target blood pressure is less than 140/90 millimeters of mercury. In the patient population who is over age 60, the guideline recommended backing off on treatment to allow those patients to, in fact, be treated to a higher, 10 millimeters of mercury, higher systolic blood pressure target of less than 150/90 rather than 140/90. Now, when I say that this is represents a backing off, these are the J&C. There have been 7 J&Cs. Now, J&Cs were previous guidelines that were, in fact, developed by NIH, NHLBI, Heart, Lung, and Blood Institute at NIH. And since the J&C5, which was in 1993, the target blood pressure has been less than 140/90. So we're talking about more than 20 years that the blood pressure target has been less than 140/90. In the latest guideline, the panel recommended raising the target to less than 150/90, or backing off on treatment. Now, these are the members of the panel. I was one. The panel was represented by patients with, individuals with marked expertise and specialties, represented here by individuals with clinical trials experience in cardiology, nephrology, general internal medicine, epidemiologists. There were 3 black individuals who were on this panel: myself, Dr. Olubenga Ogedegbe, as well as Dr. George Menza, who now directs the center, a National Center for Translational Science and Implementation at National Heart, Lung, and Blood Institute, who had to leave the panel because of job conflicts. So this was the panel that published the guideline to raise the blood pressure target from 140/90 to 150/90. A group of us who participated, there were 5 of us who participated on that panel, included Dr. Ogedegbe, as well as others, published this minority report about shortly after the guideline was published in the Journal of the American Medical Association. This was published in the Annals of Internal Medicine about a month later, where we challenged the recommendation to raise and back off on treatment. And this was for several reasons. One is the fact that we're not talking about a small population. In fact, if you look at the prevalence of hypertension, those patients, with increasing age, the prevalence of high blood pressure increases. And in fact, most of the patients with high blood pressure are in fact over age 60. Not only that, but this also represents, on this slide, if you look at the graph, on the left-hand side is the increasing risk of, this is ischemic heart disease mortality. And at the bottom is the systolic blood pressure, so that with increasing systolic blood pressure, the risk of, in this case, ischemic heart disease increases. In addition, the same is seen with stroke, the same is seen with heart failure, same is seen with all cardiovascular disease. With increasing blood pressure, the risk of those hypertensive complications increases. But even more importantly, if you go up the left side of the slide from graph to graph based on age, if you look at increasing blood pressure, you can increase the risk of complication by 2 to 4-fold. But as you go from increasing age, going from 40 to 49 up through 80 to 89, the risk increases dramatically. And in fact, it starts out at 1, and this is per 100,000, all the way up to 64. So you have essentially a 64-fold increase in risk of hypertensive complications. And here at 140/90, you see the risk continues to increase. And in fact, if you look on this slide, this was an analysis drafted by NHLBI for this manuscript. And across the top, you see age above and below age 65. You see the annual death rate per 100,000. This is during the years 1989 to 1998, and then from 1999 to 2010. And as you go down for coronary heart disease, CHD or coronary heart disease, what you see is that from 1989 to 1998, it was 36 per 100,000. In those less than age 65. In those over age 65, it goes up to 1,319, a 35-fold increase in risk of this complication. The same holds in the next decade from 1999 to 2010. For stroke, the increase in risk with age is even greater. You talk about a 50-fold increase in risk of stroke in a patient who is age 65 compared to those who are age less than 65. So we're talking about essentially backing off on treatment in a patient population that is at highest risk. And I don't have to mention for this group the risk of black race. I mean, clearly for, compared to non-blacks, the risk for mortality, risk for non-fatal strokes, risk for fatal strokes, risk for heart disease deaths, risk for kidney disease is dramatically increased in blacks versus non-blacks. Blood pressure has, in fact, since the 1993, in fact, blood pressure has been decreasing in this country, and even in patients over age 60. This is a graph shows that the reduction in blood pressure, Dr. Puckrein mentioned there's always a lag time between a change in treatment and before you begin to see the effect. Well, certainly during the decade between 2010 between 2000 and 2010, it's been a 10 millimeter of mercury reduction in systolic blood pressure, even in patients over age 60. And in fact, 82% of patients over age 60 are on medication being treated. The median systolic blood pressure in patients who are untreated, who are on antihypertensive treatment now is 135. Treatment of the median blood pressure in those who are untreated is 152. So that by raising the target from 140 to 150, that gives license to back off on treatment in those who are already being treated. And it also means that essentially half of the patients who are untreated no longer qualify to be treated. And that's the impact of those guidelines. Shows that with the reduction in blood pressure has also been associated with a reduction in cardiovascular events. Here is strokes, and as you can see, the green line is the graph in blacks. You see that even in blacks, there has been a progressive decrease in blood pressure, in stroke rates with the reduction in blood pressure. But even still, control rates in the black community are worse than in the majority community. And blood pressure, it runs slightly higher in blacks. But still, we're seeing benefit of the 140/90 blood pressure. The other point to make about the guideline that was just released is the fact that the guideline was, the panel was formed by NHLBI just as other previous U.S. guidelines. But the current report did not go through the approval process that other U.S. guidelines have gone through. Previous guidelines went through 39 organizations and professional organizations prior to their release. This guideline went out for external review, but was not endorsed neither by NHLBI, NIH, nor these other professional organizations. And though published as a grade A recommendation, it was the approval of that recommendation was not unanimous. As we indicated, there were 5 votes against that recommendation, only one more, and that would not have been a recommendation. As a result of the guideline recommendation, there have been other publications that have also been critical of the guideline. This one published by the representatives of the ACC and the Association of Black Cardiologists. Dr. Ferdinand, who is here, was among the authors of that guideline. Dr. Akinboboye was on that panel. Kim Williams, who in addition to being an ABC member is now president of the ACC, and other authors drafted this critical of the new guideline. And in fact, the American Heart Association and the American College of Cardiology announced that they would publish another guideline, and that while that guideline was being published, they recommended that the 2003 guideline, U.S. guideline, be the national standard. That panel that is drafting the new guideline had its first meeting in November, and we continue to meet. The other issue is that there is an ongoing trial that is looking at not only 140/90, but in fact an even lower target going down. This is a study that has been going on since 2010. It's been going on for 5 years. Data Safety and Monitoring Board has been watching this study. They last reported out 3 weeks ago, saw no difficulty with with continuing the study. It's being done in 100 centers around the country, 9,000 patients. Not only are the patients less than 60, but 30% of the patients in this study are in fact over 75. And there's only 1 year left in follow-up, and we will have the results from this study. So certainly, the backing off on that guideline on treatment was premature. And finally, if you look at, this is a study, this is a survey that is in many hypertension specialists have seen over and over again. And this shows, in fact, that with a 20 millimeter of mercury reduction in blood pressure, this is a survey in 61 studies, over 1 million patients, that for every 20 millimeters of mercury reduction in systolic blood pressure, you reduce the complication rates by half. And so that if reduce the complication by half for every 20 millimeters of mercury reduction in systolic blood pressure, what is the effect of raising by 10 millimeters of mercury? So in summary, age is a powerful risk factor for hypertension complications, especially in blacks and also other high-risk groups. Patients who already have CVD, even if they're non-black. Patients who have multiple risk factors would also be at risk. And for the past 20 years, current recommendations less than 140/90 have been associated with dramatic reductions in hypertensive complications. There is no evidence of benefit and a clear risk of harm if we increase the blood pressure target from the 140 range to a higher goal. And this would be done in about approximately 50% of the hypertensive population, and especially in blacks. At the time the U.S. guideline was released, it was the only guideline in the world that made the recommendation to increase the blood pressure target in patients as young as 60 years of age. And though it was not an NIH-endorsed guideline, the 2014 U.S. guideline has inappropriately been assigned the credibility of past NIH guidelines. The National Committee on Quality Assurance and their HEDIS guidelines has accepted the 150/90 as the standard, and many managed care organizations are in fact adopting that. Kaiser has announced that they will adopt the 140/90. The VA has indicated that they will adopt the 150/90. And so that if the increase in systolic blood pressure is in fact followed, and it does result in an increase in cardiovascular and especially strokes, then I firmly believe this has been an inappropriate test, and for that matter, potentially criminally inappropriate test of the higher blood pressure target. We don't have evidence that raising it will not do this. And would encourage all policymakers to end, this is in fact a dangerous public health experiment. Thank you.
Well, good afternoon. It's a pleasure to speak at this forum one more time. My charge this afternoon is to speak to you on the guidelines for pharmacologic treatment of heart failure in African American patients. Well, these are my disclosures. I'm obligated by the American Board of Internal Medicine to disclose that nothing I will say here will ever have any direct link with any board exam. So those who are preparing for the board exam can safely turn off their recorders. I thought what might be helpful, at least in terms of providing a springboard for my story this afternoon, is to sort of do a quick review of the epidemiology of heart failure in African Americans. The data show that there are approximately 600,000 African American patients with heart failure. I think is a gross underestimate. And when you look at the prevalence of heart failure, you compare African Americans to Caucasians, it's 4.2% in African Americans and 2.4% in Caucasians. But when you look at the likelihood of developing heart failure before age 50, it is actually 50 times higher in African Americans than in Caucasians. So in general, heart failure tends to develop significantly earlier in African Americans. Now, when you also look at the prognosis, is actually significantly worse. You're talking about 2.5 times higher risk of heart failure related mortality, looking at the age bracket of 45 to 64. If you look at men, 1.8 times higher mortality in African American men compared with Caucasians, 2.5 times higher mortality in African American women compared with Caucasians, and 42% higher risk of being admitted for heart failure. And of course, this would suggest that the mechanisms of the disease and of course response to pharmacologic treatment are significantly different between African Americans and Caucasians. Now, yes, with all the noise about recurrent admissions for heart failure, we've seen a decline across the board, but one group that has shown the lowest rate of decline of heart failure admissions really are black men. Now, I think it's also important to define exactly what the type of heart failure that I'm talking about here. Clearly, there are different types of heart failure. We have heart failure with reduced ejection fraction, the so-called HFrEF. These are patients with signs and symptoms of heart failure with ejection fraction less than or equal to 40%. Then you have heart failure with preserved ejection fraction, HFpEF. These are people with heart failure with ejection fractions of 50% or more. And then you have HFpEF borderline. These are people with ejection fractions between 41 to 49% and signs and symptoms of heart failure. And then you have HFpEF improved. These are patients who used to have HFrEF, but then over time with treatment have improved their ejection fractions. So because we don't have any clearly proven therapy for HFpEF, I will be focusing mainly in this presentation on heart failure with reduced ejection fraction. And to further characterize this a little bit better, again, we have the different stages of heart failure. Stage A being those who are at risk for heart failure. Stage B, those who have structural heart disease but without signs and symptoms of heart failure. Stage C being those who have structural heart disease but have had prior or have current symptoms of heart failure. And of course, stage D being refractory heart failure. So I will be focusing mainly on stage C. So looking at the guidelines for HFrEF, stage C, clearly the the crux of the management is focused on treating patients with angiotensin modulators, either ACE inhibitors or angiotensin receptor blockers, and a beta blocker. Now, for those who are fluid overloaded, you clearly want to use loop diuretics to get them euvolemic. And on the right side, for patients who do not have severe renal failure and who have fairly decent potassium levels, who are not significantly hyperkalemic, you want to include an aldosterone antagonist in your regimen. But I just want to focus your attention on the group in the middle here. These are patients who are self-described or self-identified African Americans who remain persistently symptomatic on baseline treatment with ACE inhibitors and beta blockers. These are patients who have been recommended to be treated with a combination of hydralazine and isosorbide dinitrate. And this recommendation is based on the results of this of the landmark AHEF trial, which was published in the New England Journal in 2005, which led to FDA's approval of fixed-dose hydralazine and isosorbide dinitrate, brand name being Bidel, for treatment of heart failure in African Americans. Now, just to quickly rehash the highlights of the AHEF trial. Here we're looking at patients with HFrEF, heart failure with reduced ejection fraction, and who are on a baseline of beta blockers, ACE inhibitors, and aldosterone antagonists. Treating them with fixed-dose hydralazine and isosorbide dinitrate resulted in an additional 43% improvement in survival, 39% improvement in risk of forced admission for heart failure, and 107% improvement in self-reported patient functional status. Now, when you compare the different therapies in terms of their relative efficacies, you see that with angiotensin modulators, you get about 17% relative risk reduction. With beta blockers, you get about 34%. With aldosterone antagonists, about 30%. But with the fixed-dose combination, hydralazine and isosorbide dinitrate, you get 43% relative risk reduction in mortality. Now, when you look at the number to treat to achieve this mortality reduction, you're talking about 26 patients with ACE inhibition, 9 with beta blockers, 6 with aldosterone antagonists, and just 7 with a combination of hydralazine and isosorbide dinitrate. So these are very effective therapies. Now, when you look at the relative risk reduction in heart failure admissions, 31% for ACE inhibition, 41% for beta blockers, 35% for aldosterone antagonists, and 33% for combination isosorbide and hydralazine. Now, just to sort of point out the highlights of these 2013 ACC-AHA guidelines, it clearly recommends that a fixed-dose combination of isosorbide dinitrate and hydralazine as adjunctive therapy for self-identified African Americans with heart failure who remain symptomatic despite concomitant use of angiotensin modulators, beta blockers, and aldosterone antagonists, that these patients should receive. It's not a question of whether you feel like it or not. They should receive that combination of isosorbide dinitrate and hydralazine. But what is really disturbing is that the vast majority of African Americans are not receiving this level 1 treatment. Actually, in this data by Clyde Yancey, only about 7% of African Americans who are clinically eligible for the therapy are receiving it. And actually, in another yet-to-be-published data, a collaborative effort between the National Minority Quality Forum and the Association of Black Cardiologists, an effort that is led by our own Dr. Parkering, looking at data in Medicare Part D patients, it appears that the numbers are even significantly lower. We're talking about 1.5% of people who are eligible for these therapies that are actually receiving them. So we can estimate that about close to 7,000 black patients are dying prematurely every year because they are not receiving or adhering to standard of care therapies. So, I mean, and that's the whole basis for this for this group, the Biodiversity Heart Failure Alliance, which is basically poised to serve as a voice for the more than 600,000 African Americans living with heart failure. And this is a call to action to directors of government programs and commercial health plans, leaders of organized medicine, health systems, and payers to really focus on developing a nationwide heart failure quality improvement initiative to ensure that all African Americans with heart failure receive the proper standard of care. I thank you.
Thank you to all our panelists. As I said, we are running a little behind on time, so unfortunately we won't be able to take questions now, but please do follow up with them afterwards if you have any questions. And now we will segue to our luncheon. Thank you, everyone.